Hi everyone, and welcome to Fundamentals Chapter 21, Oxygenation. So there is a normal mixture of oxygen and other gases in the environment. An oxygen analyzer indicates approximately 21% oxygen in the Earth's atmosphere. Each cell of the human body uses oxygen to metabolize nutrients and produce energy. And without oxygen, you have cell death, and that can occur rapidly. So, inspiration and expiration, we have ventilation, which is the movement of air in and out of the lungs, and this facilitates respirations. Respiration is then the exchange of oxygen and carbon dioxide. So, we have external and internal respiration. External respiration takes place at the most distal point in the airway, between the alveolar and the capillary membranes, while internal respiration occurs at the cellular level between hemoglobin and body cells. So, the physical assessment of oxygenation includes monitoring the client's respiratory rate, so how fast is the client breathing? Observing the breathing pattern and effort. Is their pattern even? Is it labored? Are they requiring a lot of effort? Use of accessory muscles. And look for chest symmetry. Also, auscultating lung sounds. Continuing with our oxygen assessment, we will use an ABG, also known as an arterial blood gas, and this measures the percentage of hemoglobin saturated with oxygen. Having an ABG drawn is invasive and very painful, so you need to educate the patient. ABGs are much more accurate than a pulse ox, and they can show the need for additional oxygen if needed. These are usually performed on acutely ill clients on an inpatient basis. Pulse oximeters are composed of a sensor and a microprocessor. This is a non-invasive transcutaneous technique for periodically or continuous monitoring of oxygen saturation in the blood. So here is a table that shows your normal and abnormal findings for an arterial blood gas. You will learn more about arterial blood gases in respiratory in MedSurg 1. When you are using a pulse oximeter, know that edema in the hands and thick nails can alter or impair your pulse ox reading. So where else could you attach a pulse ox to? Well, you could place it on a toe. You can also place a pulse ox on an earlobe. They do have some continuous pulse ox monitors that you can place on the forehead as well. So during a arterial blood gas test, the nurse should implement measures to prevent complications after the procedure. So know that an arterial blood gas is drawn from an artery, usually a radial artery. Occasionally they will use a brachial artery or even a femoral artery. So complications from that could be excessive bleeding and hematoma. So the nurse needs to be aware of that and apply pressure and look for complications after that procedure to make sure that the patient's not bleeding out or losing any blood. So it's very important to know the common signs of inadequate oxygenation. These include decreased energy, restlessness, rapid shallow breathing, rapid heart rate, having to sit up to breathe, nasal flaring, use of accessory muscles, hypertension, sleepiness, confusion, stupor, coma, and agitation. Sometimes you may see pallor, cyanosis, and increased respirations as well, and that's a result of inadequate oxygenation. On the right, you have a table that shows early and late signs of poor oxygenation. This is just to give you a comparison chart to look at. So once you see these early signs and symptoms, when you get to the late signs and symptoms, your patient is in trouble and could possibly have respiratory arrest once you get to the late stages. So that's why it's so important to know the early signs and symptoms of poor oxygenation. So how do we promote oxygenation? Well, first of all, positioning is very important. So you want that patient sitting up. You want them in that Fowler's or that semi-Fowler's position. You want to do some deep breathing techniques. You want to have the patient take some good deep breaths to maximize that ventilation, taking in large volumes of air to the alveoli. That helps increase or improve that gas exchange. Pursed lip breathing is a form of controlled ventilation, and that can help the patient consciously prolong the expiration phase of breathing, and that helps the client to eliminate more than usual the carbon dioxide, so they can get rid of that carbon dioxide by using that pursed lip breathing. Use of an incentive spirometer. So whenever that patient comes back from surgery, they have an incentive spirometer ordered. We as nurses need to make sure that that patient is using that incentive spirometer. We need to teach them how to use it and encourage the use of that. Nasal strips can be used. Diaphragmatic breathing is breathing that promotes the use of the diaphragm rather than the upper chest muscles, and it's used to increase the volume of air exchange during inspiration and expiration. But positioning the patient should be something you do first. Get them in a good, adequate position so that they can expand their lungs, and that should be the first thing you should go to. And then apply some oxygen as needed. Like I said, having the patient sit in an upright position will help with that lung expansion. As you see the picture on the right, the lady is leaning across the bedside table. This is called tripod position, and that tripod position is something we'll put a COPD patient in who is having some exacerbation or some increased respiratory difficulty. We'll place them in that tripod position to facilitate their breathing. Sometimes we have to take deep breaths ourselves to relax. You can do a 4-7-8 technique where you inhale for a count of 4, hold for a count of 7, and exhale for a count of 8. Using this type of breathing will help you relax whenever you're feeling stressed or anxious or upset. Sometimes you can just do some relaxation breathing for yourself. So remember, I said it's very important that we get our patients to use that incentive spirometer. And not only is it used after surgery, but you can also use an incentive spirometer for patients who have some type of lung disorder like COPD or pneumonia to get them to deep breathe and just facilitate that lung expansion. So for optimum lung expansion, have the patient sitting in that upright position, preferably a Fowler's or a semi-Fowler's position. So now we're going to move into oxygen therapy and oxygen devices. We have wall outlets, portable tanks, liquid oxygen units, and oxygen concentrators. And these are just types of equipment that's used with the administration of oxygen. The most common potential problem that the nurse can face when using liquid oxygen is the fact that it can leak or evaporate during warmer weather. Know that those portable tanks can be bulky and may require constant filling, so you have to have some home help to help the client with the refill of those portable tanks. And then wall outlets are what you're going to see in the hospital setting. You're going to see the wall outlets used in the hospital setting. Other equipment we use with oxygen could be a humidifier. An example of that is on the left, and a humidifier is just sterile water, and that's used to keep the mucous membranes moist. On the right, there's a picture of the flow meter, and the flow meter is used to regulate the amount of oxygen delivered to the client, and you can use that to adjust it to whatever setting the doctor has ordered. We typically use humidified oxygen when we get to 4 liters or more. So when you are administering 4 liters or more of oxygen, you need to consider putting a humidifier on because oxygen is very drying. Again, you can also apply the humidified oxygen for someone who's receiving oxygen for an extended length of time. So they're receiving oxygen over several days. You may want to add that humidifier as well to facilitate that moisture so that the mucous membranes don't dry out so drastically from the use of that oxygen. So when we talk about oxygen delivery devices, we're going to start with the nasal cannula or nasal prongs, and that's what you're going to see most commonly used. We always start the patient at the lowest amount of flow, meaning we're going to start them at 1 or 2 liters of nasal cannula. We will gradually increase the oxygen as the patient responds or doesn't respond. Typically, nasal cannula is not administered over 4 liters a minute. That's usually where we stop. If we get greater than 4 liters, we switch to another device. With a nasal cannula, you have to be very mindful of skin breakdown that can occur at the ears and the soft, fleshy areas of the cheek where the oxygen tubing may lay. Also know that the nasal cannula can be very dry into the mucous membranes. If it is, you can apply humidified oxygen, even if it is a couple of liters, but it may be for an extended period of time. So, for example, some patients who may be receiving a heparin drip, which is a blood thinner, they may have a nosebleed because the oxygen is drying them out So you can always put that humidified on there if you need to keep those mucous membranes moist and from drying out. But like I said, always start with the lowest concentration first, which is generally 1 or 2 liters. And know that these nasal cannulas can become easily dislodged. Your patient can reposition in the bed, they can turn over, they can get their arms caught in it, dislodge it from their nose. Their oxygen saturations can decrease. So sometimes with certain patients, you are constantly going in and putting that nasal cannula back on. So you have your patient on 4 liters of nasal cannula, but that's not bringing their oxygen level up. You may have to switch to a higher delivery device. So we would first start with a simple mask or a venti mask and work our way up. So we want to start that, 35 or 40%. Once we get to 50%, that's about as high as we're going to go with those venti masks or those simple masks. If we have to go up any higher than that, we're usually going to switch then to 100% non-rebreather, which is a different type of mask. We'll increase that oxygen level as we need to. But when a simple mask is used to the client, you want to try that they can breathe through their mouth as well, because the mask just covers their nose and mouth, so it helps those mouth breathers out there when they have their full face right there covered with the mask. That's very helpful with that. Additional devices can be a face tent, trach, which we've already talked about, a tracheostomy collar, which is for someone who's not on the ventilator, but they can just have oxygen through a trach, and a device that's also called a T-piece. So on the left is a picture of a trach collar. You see that's just over the trach, and then the face tent is very loosely fitted to the face, and that's on the right. When receiving oxygen with a face tent, know that the oxygen is inconsistent. It's inconsistent because it's loosely fitted around the face, so it's difficult to get that constant flow of oxygen through there all the time. Whenever you have a person with a trach collar or they're on using trach O2, know that you need to have some supplemental O2 available and ready. You could use a nasal cannula or an ambu bag, something to facilitate some oxygen through that tracheal opening. You can use what's called tracheal oxygen, and that's for those with long-term trachs and they just need a low flow oxygen, but it's called transtracheal oxygen, and that's, like I said, used with a trach at a low level. We also have oxygen tents that you can see lots of times used with children. We also have what's called CPAP and BiPAP mask. These masks provide CPAP provides pressurized O2, and it's very continuous. It's at a constant pressure. If the patient is using a BiPAP, that is a 2 pressure setting device for inhalation and exhalation. You will see the CPAP or BiPAP used for patients with sleep apnea. The mask must be maintained and cleaned on a regular basis. Generally, they wear it at night, or if they take naps during the day, they may need to put their CPAP or BiPAP on during the day to help them with their breathing and to hopefully not develop any sleep apnea during the day. I was really pleased to hear a lot of you talked about fire and no smoking when oxygen is in use. That's very important when a person has home oxygen. Those signs and warning signs need to be posted everywhere at the home for the home oxygen user. They also need to have fire extinguishers on hand. They need to use cotton fabrics. Make sure that the electrical devices are functioning properly. Everything should be grounded, and just stay away from flame. Safety is very important and to prevent fires when oxygen is in use. And yes, patients do smoke while using their oxygen at home. They do smoke while they use oxygen at home. That happens a lot. But it's our job as nurses to document that we educated them not to smoke and use oxygen at home. So believe it or not, we can cause toxicity with oxygen. And that's because the oxygen may be used for too long of a period of time. The oxygen concentration was too high, and the severity of the lung disease caused or had an impact on the oxygen toxicity. So whenever you are administering oxygen, especially to a critical care patient, and you're using a non-rebreather mask, which is generally 100%, you always need to remember that the oxygen concentration of 50% or more given longer than 48 hours can cause oxygen toxicity. So that's why we try to wean or decrease that amount of oxygen as quickly as possible, because sometimes you are unaware of the severity of someone's lung disease. So those high levels of oxygen, even 50% for 48, 72 hours, something like that, can be very detrimental to someone with COPD. So you have to stay on top of that and try to get them to lower amounts of oxygen as quickly as possible. That's one of the reasons why we start with only a couple of liters at the time, so that we can hopefully avoid that from happening. So what does an oxygen toxic patient look like? Where they're going to have a non-productive cough because that long sustained period of high concentrated oxygen has just dried out their mucous membranes. They can have substernal chest pain, nasal stuffiness. They may complain of some nausea, vomiting. They can be very fatigued, very headachy. They may complain of that headache, sore throat. That oxygen's blowing in at 50% all the time, or 100% is blowing in. It's causing their throat to be sore. And you will actually see their ventilations slow. Their respirations will become shallow, and their respiratory rate will actually decrease. So always use the lowest level of oxygen first. Always use that. Monitor your ABG. Know that the ABG is more accurate than a pulse oximeter. If you don't have access to that ABG, use that pulse oximeter. Know that you got to look if your reading on your pulse oximeter is being impeded by edema, some type of swelling. Do you need to move that pulse ox to another digit or to the toes or the earlobe to get a better reading? But monitor your ABG, monitor your pulse ox, and decrease that FiO2, which is your oxygen percentage. Decrease that as the client improves. If you need a physician's order to decrease that oxygen, get a physician's order. But decrease the oxygen just as quickly as you can, and that way you can avoid some oxygen toxicity. A couple of other techniques that are oxygen related is the use of a water seal chest tube drainage, and this is a technique for evacuating air or blood from the pleural cavity. It's actually inserted into the pleural cavity. You can see this with a collapsed lung, say from a stabbing, from a trauma from a car accident, even with a surgery like a thoracotomy. You will see the use of a chest tube. Then you have hyperbaric oxygen therapy, and this delivers 100% oxygen at 3 times the normal atmospheric pressure within an airtight chamber. Know that whenever you're using hyperbaric oxygen, you need to give the patient frequent breaks during their treatment. So you need to actually pull them out of the chamber frequently so they don't become oxygen toxic. A couple of other things that we use, oxygen related techniques, is the use of a water sealed chest tube drainage, which is a technique for evacuating air or blood from the pleural cavity. That's where it's inserted. It's inserted in the pleural cavity. You'll see this with a collapsed lung, say from a trauma like a stabbing or a car accident, or even a thoracotomy like a surgery. We can use hyperbaric oxygen therapy, and that's the delivery of 100% oxygen at 3 times the normal atmospheric pressure within an airtight chamber. You may see that in use as well. If your patient is receiving hyperbaric oxygen therapy, you need to occasionally provide them breaks, bring them out of the device, let them get some room air. You don't want them to constantly get that 100%. You want to give them frequent breaks between during that hyperbaric treatment. So make sure that you pull them out of the chamber and give them frequent breaks throughout their therapy. With a chest tube device, this is a chamber that collects blood or acts as an exit route for pleural air, which is the drainage chamber. You have a second chamber that holds water that prevents atmospheric air from re-entering the pleural space. That's your water seal chamber. You rarely see a third chamber, but occasionally you do, and that could be to suction or vented to room air. So whenever you're using that chest tube, always make sure it stays below chest level. Never pick that chest tube drainage system above the chest. Do not place it on top of the mattress in the bed with the patient. It always has to be below chest level. If you raise that chest tube above chest level, you may cause the pneumothorax or the pleural space to become worse. Whenever using that sealed chest tube, the nurse should never separate the chest tube from the drainage system. You don't clamp it. The only people who are going to clamp it is going to be like a physician, or unless the physician is standing there and tells you to clamp it. But normally we do not clamp a chest tube as a nurse, and you're not going to disconnect that chest tube either. You can access this video on your PowerPoint slides if you like, and this just is an example of chest tube setup and maintenance. So once again, we have concerns for our geriatric population. Know that they have reduced gas exchange. A lot of that is age related because, as they age, that respiratory system becomes weaker. Those respiratory muscles become weaker. That chest wall becomes stiffer. So it's a little bit harder for them to take those good deep breaths to get that oxygen level up. They have that diminished cough. That gag reflex is also diminished. And they also have increased use of accessory muscles when they're breathing, especially if they're short of breath. And they have more mouth breathing and snoring as they age too. So you may have inactive or debilitated or chronically ill clients or smokers, and they are at higher risk for respiratory infections and compromised respiratory function. So you need to make sure that you are staying on top of that and getting that patient to turn frequently, take good deep breaths, getting them to cough, all those things to facilitate good lung and oxygen exchange to prevent any type of respiratory failure or respiratory complication from happening. And that concludes our Oxygen Chapter 21 for Fundamentals. Thank you.